best I could figure on all of it together. I work everywhere. I do acute care, med-surg, starting to do a little more in the ICU. I also have a position in the ER and just finished my certificate to do critical care transport flights.
Oh, congratulations.
Thank you. That was hard. That was brutal, by the way. If any of you are thinking about doing that, that is not an easy class to get through.
It should be.
So I do a little bit of everything, so we have lots of knowledge, lots of resources when you guys come to work with us during your clinical rotation. I'll pass to Jen.
I'm Jen. Was in from Fort Kent. I actually don't recognize any of you, so I must be getting old, so I apologize. I started at Cary, I think 13 years ago as a secretary, and I did that for a little while. I worked as a CNA while I was in school and got my RN from NM, what they're saying, and I've been having babies, so I haven't gotten my BSN yet, but it was one or the other, and babies kind of took over, so we have a lot of fun at Cary, and I hope to see a lot of you guys there. If any of you apply, I'll see you through the interviewing process, unless I'm out having babies. So welcome whenever you come to our facility, and hopefully you enjoy it, and if there's ever anything that you don't like, or if there's any issues that you come across, please let us know, so we can fix it right away, because we enjoy having you guys there. So we'll just share a little bit of our experiences with you for the next couple hours. So that's it. We'll get started.
About 4, maybe 5 years ago, I was working, doing some education, training new nurses that came onto the unit, and noticed that there's a lot of deficiency as far as when new nurses come out and their knowledge about charting and how to chart, and then over the years, a lot of bad habits were developing. And I went to a class on nursing documentation. It was a workshop weekend thing. And there was a nurse there who works as a legal assistant and does mediation. And she had put together a presentation much like this one. And what I learned from her was so immense and so shocking to me. It kind of made me reevaluate myself and how I document, and kind of felt a need to start teaching other people about that. So after going to 2 or 3 different documentation workshops and learning a lot, I sat down with Christy Ewing, and we kind of developed this program. We've done it, I think this is the 4th time I've presented this one. And I feel like you could all learn this from the gate, right? Coming out, already knowing the information, and that way it will kind of make you aware, make you more specific in your charting, and hopefully stop you from developing some bad habits early on, because it's really easy to do. So we'll kind of get into this now and kind of get you looking at. So we're going to look at the regulation requirements. There's probably some stuff you guys have started to hear, Joint Commission, CMS. We're going to talk about that a little bit. That way you have some awareness of how that transcends into your documentation. Basic elements of documentation. So the Joint Commission and the state of Maine, they mandate the regulations and standards of practice. Hospitals can be Joint Commission accredited or not. There's very specific guidelines that have to be met for them to meet that, to get that accreditation. And now it also has a lot to do with insurance reimbursement, Medicare. You're hearing about Obamacare and all that. This is all comes back to payment, and your documentation supports that. State of Maine also has a lot to do with it, and the CMS, the Centers for Medicare, they decide how much you get paid and then what they're not going to pay for. And your documentation also reflects that. Nurse Practice Act, your nursing scope and standards of practice through American Nurses Association, and then your facility will have a policy and procedure on documentation as well.
And how often you have to do it, and kind of making sure you get specific things in each session of documentation.
I really took that one.
The definition of standard of care, it sets up what a reasonable prudent person, what a professional person with similar expertise would have done in that similar circumstance. So if you ever get called into court, which can happen, everything you're doing can be brought back, and it does have years that you could be called back on a patient that you took care of for one day, one shift, 5 years ago. They will compare you to another, what any reasonable prudent person would have done in that circumstance and see if you are negligent or not. So negligence can be defined as failure to comply with those standards of care. So omission of doing something is failure to do something. Commission is actually having done something and it being wrong and against the normal standard of care. Nurses are expected to conduct themselves in accordance with nursing practice, with what are accepted rules and what has been established by the years and years and years of experience of nursing. This isn't the first decade of nursing, so these things have been researched and practiced. Going over negligence, professional negligence is failure to provide the prevailing standard of care to patients. So something that you've done has caused some type of injury or damage or loss to the patient. Patients can die from some types of personal negligence. So,
Can any of you think of an example of what would be negligence? What's something, so providing the prevailing standard of care which results in injury or damage or loss to the patient. So something simple.
A med error.
A med error, yeah.
Leaving water on the
Forgetting
floor.
to put someone on a cardiac monitor when you're administering cardiac meds.
Does this necessarily mean death also or no?
No, loss. Injury. So you don't put them on the heart monitor, or you don't document that you put them on the heart monitor while you're pushing IV metoprolol. And the patient ends up having an asystole event or something. So unless you documented that you did that, then you could be charged with negligence.
the thing with documentation is, and I'm sure they've already taught you in school, is if you don't document it, it didn't happen. I would imagine you guys have heard that somewhere along the way. So it really does carry through with you even outside of school and through your entire nursing practice. If you didn't document it, it didn't happen. You can go all day and night and spend 12 hours with a patient and have done everything under the sun to them, but if you didn't document it, then you're not going to get the credit for it legally. If you get called 6 or 7 years, which is about the time span that they can call you back to court, if you get called for that and you had that patient, I'm sure if I asked Lara, geez, Lara, 5 years ago you had
Last week.
so-and-so as a patient and, like you said, you forgot to put them on the cardiac monitor, can you tell me why? Pretty sure you're not gonna be able to remember what happened 5 years ago with one patient that you had only seen once in your entire nursing career. Some patients you get used to and you know them and you know their usual pattern of things and you can remember, oh yeah, I remember what happened with, that Joe Smith, 2 years ago because that was when this happened and you get close to some of the patients and you know them, but most of them you're not gonna remember what happened like you said last week. So documentation is what's going to save you and save that patient and save your facility possibly.
And legally, the bottom point is very important. The burden of proof is on you, or on the plaintiff. So they have to prove you did it wrong. You have to prove with your documentation that you did it right. So that, the burden of proof is on the plaintiff, but you have to back yourself up. And the only thing you're gonna have to do that with 6 to 7 years later is going to be your documentation.
I don't know how many people have the nursing and organization insurance.
Not many.
Not many.
Not
Very
many at
few.
all.
They sent out a really good bulletin in the mail this week on how to get ready for what do you call it?
Being disclosed,
Yeah.
Deposition, that's the word.
Yes, and what would be asked of you and how your lawyer gets you ready and what kind of information you give is really good.
And I don't know if any of you have ever been called to court, and not many nurses do luckily, but they will ask you the same question 3 or 4 times to try to trip you up. So most nurses, are not, set up to be in a courtroom and having to go over these things. So it's it's very easy to trip up on yourself because that's what they're trying to do. They're trying to get you to say something that they want you to say. So sticking close to what you've documented and staying to that in entirety is very important. I'm sure you guys have heard of different cases where entire nursing units have been called to testify. It's very important that you know what happened and that you stick with it and that you support yourself and, you know, not get tripped up in it.
So the legal implications of all this are basic. You can lose your license, which, you know, you've worked all these years to get. You know, it would really suck to have that just taken away over one event. Lawsuits against yourself, your person, your hospital. All of your notes are considered documentary evidence. So what will happen is the lawyer for the person that's suing will come in and they'll get that medical record. They'll take every bit of it and they'll have a nurse on the other end who's a legal aid person or maybe a nurse attorney as well. Will go through and they know what they're looking for. They, you know, unfortunately they're very aware of what it is that they're looking for and you don't in that moment. You know, you're going through your day, you're doing your thing. You're not thinking 5 years down the road. So that's what we're going to try to get you to be thinking about is 5 years down the road as you start your process.
One of the things with documentation is that you should be just factual and just in the moment and not speaking of what a previous shift has done. If you were to document, you know, Heidi's one of my coworkers. Heidi was on during the day shift and she failed to change the dressing as, you know, Dr. Menziwe had ordered. And it made me very upset that she didn't change this because now I have to do it and the patient was found to have issues with their wound or something along those lines. That could be called back against Heidi in court. So it's very important that you just document what's going on during your shift and what's ever happening and that you don't speak about a shift before or 2 shifts before or what happened to them on admission. If you weren't there, you really didn't know, you really can't say legally and factually what was going on and what happened. So just stick to yourself.
We've already talked about the standards of care briefly. And then the Joint Commission State Board of Nursing mandates that hospital documentation be accurately recorded in a timely manner. We're going to talk about that in a little while. Timely manner and accessible to the appropriate personnel. So basically, it's just saying that you document effectively, you document timely, and that other people, like the next shift, is going to be able to access my notes and read my notes when they come onto their shift. So you're not going back 2 days later and deciding to put notes in that, oh yeah, maybe I should have wrote that. You know what I mean? You have to do it in the moment, in that day. You're not just, I mean, every now and then there's gonna be some late entry thing you have to fix because somebody noticed something, you forgot to put something in. That's different. I'm talking about your assessments on a daily basis. And that's a requirement.
Sorry.
That's okay.
One of the things that's come back to us from hospitals have people that come in and evaluate how they do things, and Joint Commission comes in to reevaluate us every so often to keep our accreditation. One of the things that came up to us was, boys, if your documentation all day is at 0800, 10 o'clock, 12 o'clock, 1400, 1600, looks a little suspicious if you're exactly in that room right on the minute of the hour. Every time you go in, be charting at your actual time that you did something, even if, you know, boys, I had to run out for an emergency and I didn't get to chart on that patient in 206. Well, note what your time was whenever you go into a room, jot it down. I was in that room at 12:57. Put your documentation. You can always, doesn't matter what system that you're working with, you can always change your time back. Put it at the actual time that you were in there. It makes a difference. Let's say if I go in and I'm documenting something about blood pressure that I took. Lara goes to give blood pressure medications. If we mix up those times, it may look like, well, geez, that blood pressure med that she gave really wasn't effective, but guess we got to give more. If the blood pressure was taken after and it was still higher, that's when, you know, if the physician's looking at the documentation. So it's very important that you document the actual time that you're doing things. It really does, when we're reviewing charts, it really does look suspicious if you're right on the minute of every hour.
We put this in here
Oh yeah, a couple years ago.
Yeah.
We went to,
because one of the documentation workshops that we went to, it was a nurse attorney, and she was talking about, so social media and how it's affecting nursing legally now. So we put it in with our legal part there. You guys need to be really very, very aware as you're coming out of school and you're getting your licensure, because you are held to a higher standard. And it's starting to happen where employers are looking at your Facebook, they're seeing what you're doing, they're looking at your posts, they're looking at your pictures, and it's starting to affect nurses negatively. You may go on vacation and it seems really unfair that you got fired because you were dancing on a bar table in your bikini top, you know, in Karuba. But it's happening, so you guys need to be very, very aware. Also, going home and saying, crappy night bell ringers all night long. Okay, well, Aunt Susie's cousin is friends with your friend, and now she saw you put that on Facebook, and, well, oh, so she said that my Aunt Susie was being a pain in the butt all night. Not so professional. So you guys need to be really, really, really aware of what you're putting out there, because it's gonna come back and haunt you when you're going for job interviews. They're starting to do that. They're looking at people's stuff ahead of time.
They had an incident at NM a year ago of a medical assistant student that had went to clinical at the Walmart clinic, when they had the Walmart walking clinic. And she had posted on Facebook all about the clinic and what she had done and everything. She was thrown out of the program.
Yeah.
So that situation seems appropriate. In the situation that you were talking about before, can the facility specifically say, like, is specifically because of this picture, or would you just?
I
try to
would imagine
confirm
it's
something
by
else?
facility, but when you get hired in those
Yeah.
places, you're gonna be signing standards of behavior,
Okay.
Stuff like that.
Yeah.
There's a lot of fine print. If you really read it, it actually has a lot about social media. More places are getting into their cell phone use, computer use, different things like that. I see some of my friends posting. I have a friend that's, she's a cardiac nurse practitioner in Florida, and she posts things, and I'm pretty sure that's a violation. She'll say, 78-year-old male came in to see me today, and he was so cute with his wife, and they went on about this and that and the other thing, and you're really cutting close to that
Well,
line.
anything
So,
about the patient, I would understand.
right.
I was just wondering if they.
Yourself, yeah.
The thing is with facilities is, just as your students right now, you're representing the school. That's where it all comes back to. So you really don't want to be putting, once you get out into, you know, the world and you're on your own license, it can come back to mind. Maybe you might not get fired, but they might look at you a little bit, well, are her responsibilities really in check when she's looking for promotion or something like that?
It's also a small world, so.
Especially up here.
There might be a patient, let's say a mom, you take care of a mom's, let's say your best friend's mom, or whatever, that has access to that, to know what you're putting on there, to know what you're doing. It's really a small world, and if somebody complains that, you know, she really isn't the right one to be, I don't want her to take care of me,
Right.
because I know what's going on, you know, only
Yeah.
through social media, so.
It's scary. And, you know, it really depends on what standards of behavior you signed when you went on, when you got hired there. Whether or not they could say it's directly related to that photo, but it can sure change your employer's perception of you.
It makes sense.
Scary.
I was just wondering the legal technicalities of it, but if you're signing a behavior.
I've had new employees that, you know, when you get hired, you're under probation, whether it's for a month, 2 months, 3 months, no matter where you're hired, you're under some type of probationary period. I've had some new nurses that I've had to re-sign the standards of behavior because you might not have read this very clearly when you first got hired and things aren't, you know, lining up to that. So let's take a look at it again and re-sign it, and, you know, you're a little bit on a closer watch at that point when you have these things. Another thing with social media is the way Facebook is set up now, where, geez, I saw a post that you had, or pictures, or whatever, with someone that you're not even friends with. Lara can speak from experience with people finding out when you give any of your personal information, even if you don't. If patients try to friend you on Facebook, or whatever it might be, they may show up at your house. That's happened to Lara before. So you need to be a little bit closer with with your own personal things, with social media. So that's our motherly advice.
And remember that one thing that that nurse attorney was talking about is before you're ever hired, the employers are starting to look at that stuff before you walk in the door for your interview. So just be really, really aware of pictures, because can't forget it, right, or regret it, it's out there, it's permanent, you can't take it back. Once it hits that internet, somebody somewhere can get it. So just think about that stuff now while you're in school, and you know, if you put something out there before, you can't get it back, but don't put anything else out there. Just be really, really cognizant. Even if it's somebody else taking a picture of you. You know, you're at somebody's party and somebody's snapping pictures, you know, maybe say, yeah, don't put me in your pictures. Just think about that now.
It's hard, it's a hard job market. You want to make yourself look, you know, the best as you can. And Lara and I have both been in the process of looking at new employees when they're coming in. And if you've got this stellar person that, you know, looks responsible and all that, and it might come down to that. So, yeah.
I have a little, when I went to Tammet and did my medical just recently, I had gone into the OR and watched a knee replacement. And this is kind of along the lines of that, not so much, you know, posting pictures, but actually playing on your cell phone while you're working. And I stood behind with the anesthesiologist, kind of watching what was going on. Anesthesiologist was doing his thing, you know, very aware of what was going on and watching the meds, watching the patient. Well, another anesthesiologist came in to replace him for 15 minutes so he could take a break. And when that anesthesiologist sat, the other guy was gone, he played on his cell phone for the 15 minutes he was there. He did not once look at the monitors. He was, I mean, he might have been aware, but it just made me feel uncomfortable, you know?
Yeah.
And when the other anesthesiologist came back in, he goes, oh, everything was great, nothing happened. I'm like, oh,
Yeah.
you know?
And OR, I don't know how many of you have been through an OR, but it's a whole different world in there for sure. I know it's neither of our thing, but it is, and that's part of it, because it is a different world in there. But you'll see, like, our administrators are on the phone all the time. I usually have my phone on because I get my emails on the phone. It's changed a little bit, it's a little bit more of a gray area with having your phones around, but it's different with, if it's work purposes, or if you're sitting at the desk with your feet up, scrolling through Facebook on your smartphone, so.
And remember, it's really easy for a family member of a patient to take their phone out and take a picture of something that you did wrong or you left sitting there. I know that it's happened before where I say the stickers, we have stickers in the charts with patients' names and stuff, and maybe somebody had a sticker out and set it down for whatever reason and forgot about it. And then somebody else sees it, takes a picture of it. Oh, look, HIPAA violation, you know? So it's really, really easy for that stuff to happen, and it's just something you have to keep in the forefront of your mind. You know, I always look at my rooms before I leave the room. Should I leave anything laying out, you know? If I leave a syringe sitting somewhere because somebody's gonna take a picture of it, and so just be cognizant.
All right, so why do we document? We've already gone over a lot, some of this stuff. We talked about reviewing charts, peer review, quality management, coordination of care, so that things, you know, have good continuity, that things pass from shift to shift or from ancillary departments. So PT and nursing are both working with this patient, that things match up, so that we're all documenting somewhat the same, including the same things. You should be able to find, it shouldn't be any change from when Heidi leaves off shift to when I come on. You should be able to still pass them through each one. Legal protection, we've already talked about. Required for reimbursement. Unfortunately, nursing world is wrapped around reimbursement right now. If we didn't have reimbursement, we wouldn't have places to work. So it's kind of hurts a little bit to come back and say, well, we didn't document that, so, you know, we don't get reimbursement for that 2 days of patient. Well, that's like $2,000 right there just for the nursing care and the stay overnight, never mind medications and all that stuff. So if you, for example, if you don't document when a patient comes in from a nursing home, if they have a wound, if you don't document that that was present on admission, that's a big thing. If it looks like it started when they were at the hospital, for example, we're not going to get any pay for any type of care that had anything to do with that wound whatsoever. So it's very important that you document, you know, in its entirety, I guess.
And on the same thing with the legal protection, if the wound was there when the patient came in, but nobody documented it was there, then it would be assumed legally that it occurred on our time. And who's legally responsible when the family decides to sue because mom has a bed sore?
Us.
Who's it on? It's on us, because according to us, it wasn't there when she came in, therefore it must have occurred on our time.
Do you guys have 2 nurses do your skin checks?
No.
No, only one, okay.
Just wanted to
It's your appointment, they do now, they have.
Oh, do they?
have-
They do too.
Especially when they come from a nursing home.
Oh, I don't blame them, that's a good
They
idea.
have 2 nurses do the.
Sometimes when you're pregnant and you have a lot of morning sickness and you can't stand upright and you're vomiting a lot, sometimes your coworker will help you out with that, by example.
Also, on the quality management thing, when hospitals have quality management teams or people that come in, little committees that review something like pain assessments and pain control, all they're doing is looking at documentation. They're looking at how are we managing the patient's pain? Are we doing follow-up on the pain? You know, are we reevaluating after the follow-ups to figure out, what we're doing working? So it's all comes back to your documentation, and that's how it's looked at and reviewed.
Anytime there's any patient complaint, especially about pain, like Lara mentioned, they're going to pull from the minute that patient went into the ER or into the OR, one-day surgery, whatever it may be, they're gonna be looking at all those documentation. And if you're in a type of system that has options for you to click on and you don't type anything yourself, the person that's evaluating is gonna say, well, they were just click happy, they just clicked through everything, this isn't giving me any information. And they might not side with you when it comes to those patient complaints if you didn't give good information about, especially pain, that's really a big one that
Hot
comes
topic.
back to bite people a lot.
So your charting should reflect the nursing process. We all remember this, Nursing 101? Yeah, nursing process. The American Nursing Association Standard of Nursing Practice requires documentation to be based on the nursing process. Must follow documentation policy presented through your organization. And so we go through the assessment, diagnosis, plan, intervention, evaluate, and our documentation should reflect this throughout the patient's stay. We usually document on our nursing diagnosis. That does not go away when you leave school. You're still gonna have nursing diagnosis. And that's gonna be based on your assessment, and you're gonna be selecting those and documenting on those daily, resolving them as things resolve and new things arise. And it's usually recorded in your problem list or your care plan facility to facility. So it should be reflective of prioritization, decision-making, reevaluating, constantly reevaluating. I can't stress that enough. Every time you document that something's wrong or vital signs are off and you've intervened in some way, there should be a continuation of that. Your documentation should be flowing. It should be painting a picture of what's going on with that patient. And that's something where nurses kind of slack a little bit on that as far as documenting the reevaluation and continuing reevaluation of things and problems, whether it be a wound or a blood pressure or eyes and nose. You know, you document that you called the doctor and gave this, but did you ever document any follow-up on that?
One of the things I tell our new nurses when they're hired on, they come with me before they usually come out onto the floor or wherever they're going to be working. You need to paint a picture as though someone's not in that room so that they can look at this and say, all right, I know exactly what's going on with that patient. But at the same time, not over-documenting and setting yourself up in some type of a legal situation where you're just saying way too much. Doesn't matter what eye color the patient has or that they, have issues going on that don't relate or aren't something that's, going on or something that you're dealing with, that they're selling their house, and that they're looking for a new house and all that stuff. Doesn't really relate, don't need to go on and on about these things. It does happen. You wouldn't believe some of the documentation, that we find from people that have been there for 30 or 40 years. So, painting that picture is very important.
So all of these things tied together, all of your assessments, your reevaluations, they should be reflective of some critical thinking, and evidence-based practice. Is what you're doing working? If you continue to document that their blood pressure is 74 on 40, and you're documenting that you're giving IV fluids and you're reassessing and the blood pressure is still only in the 70s, maybe what you're doing is not working and you need a little more intervention. So your documentation should reflect that. Consistent phone calls to the doctor, You know, is the doctor giving you new orders? Is the doctor not giving you new orders? That's a big thing, you know, you notify them, but if they're not intervening appropriately, your documentation should be reflecting that. Because it's not just the doctor that's gonna be accountable for this situation, so are you. So you need to be documenting, I notified and got no orders.
It happens, even though you know, I know this patient needs this. We have some physicians, and I'm sure, and every other hospital has some physicians that you can't say, hey, Dr. So-and-so, my patient, you know, Mr. whatever, needs a bolus of fluid, or we need to hold their laces, or we need something. If you come out and tell them what the patient needs, you're guaranteed to not get it, even if that's what the patient needs. So you get creative in how you ask for things. You make it seem like it's their idea.
Lead the horse to water.
That's right. So you get better at this.
Some more than others.
It kind of gets to be a little bit of a game. Yeah.
Okay, where are we? So your charting should clearly describe the assessment of the client's health status, nursing interventions carried out, and the impact of these interventions on the outcomes. Environmental factors, safety factors, whether or not the patient's performing self-care, significant events. So, you know, a patient has chest pain, what do we document?
No one?
What do you walk in the room, I'm having chest pain.
Okay. What their pain scale is.
Okay.
Anything else? When it started, the time.
Location,
What it
okay.
falls.
The quality of the pain.
Kind of pain.
What else?
Right. What are you doing about it?
So what are some interventions you would be documenting at that moment? What else?
You can take the vitals.
That too, but what if they just go on and on with chest pain? Does it ever get better? Anything that's
Vital signs?
Yeah.
Yeah.
So you have this great note about the chest pain. You should have some vital signs associated with that note. So you intervene, you give them some nitro, you get your EKG. Now what are you documenting? Reevaluation of what?
Patient, chest pain, vitals.
Vital signs? Is the chest pain gone? Notification of the physician. Is the physician in the room? If they come in the room, you better believe I make a note that they're at that bedside.
When your EKG was done and
Right.
it was red.
Yeah, and that the doctor looked at it,
Yeah, the doctor
absolutely.
looked at it.
Because I can tell you from personal experience, I had a very good friend of mine, her husband went to the ER, he was 34, he was having chest pain, and they just kept telling him, oh, it's reflux. Well, I said, you know what, why don't you get his records? Get his records and go see somebody else. Well, there was an EKG in that chart with some significant ST elevation that was never read. Doctor never signed that EKG. He was having some significant ischemia and ended up with a quadruple bypass. Because nobody looked at it, nobody documented, nobody signed it off. So, yeah, they did it, but that doesn't mean anything. Okay?
An example I can give you guys of where documentation can come back to help you. I had a patient, I don't remember how long ago it was, but I had a patient that had come in and it wasn't a patient of ours, it was a busy time, all the hospitals were full, we happened to have the spot, so we got transferred over to us from Canada. So no one really knew him. He had a lot of other medical issues, but this was something new for him. He was having just, you know, kind of like some cold symptoms and having a hard time breathing and just weird, just different, and he knew, "God, this is just different." I admitted him. A couple hours later, he started to kind of get loopy a little bit. All that we'd really given him was nebs, but he'd gotten nebs plenty times before. In the ER, he had gotten some, we'd given him some. Kept just kind of getting a little bit more off, and I'd only known him for a couple hours, but I could see, geez, something's off. I can't put my finger on it. Take vitals. Vitals are right, my labs are okay, what's going on? His daughter came to visit, she said, gee, something's just off about him, something's going on, and it seems like he's getting a little confused. So I talked with the physician that we had on, oh, well, he's having a reaction to the nebs. Oh, well, it's this or that. Well, geez, can I get an EKG and see what's going on, you know, further than what I can do? All I can do is set vital signs or different, you know, nursing interventions. No, you don't need that, he's just having a reaction. Well, the physician never went and actually looked at the patient, never went to talk to him, never, you know, went and kind of thing. I documented my butt off. I documented every little thing that I found that was up, everything that I had done, anything possible. I left that night, and it happened to be an ICU nurse that came on after. Something's off, I can't get any more orders, and it was kind of at the change of shift where it was starting to get weird. Please help me get something, maybe she had a little bit more pull, it was a different position coming on, see if you can get something else going on. And I left that the next morning for Rhode Island for vacation, whatever, and I got a call the next morning. Did you notice this with that patient? Well, take a look at my documentation. All right, so they call back. Well, we were able to look through all your documentation and find out that this patient has H1N1. It was our first case of H1N1. It was when H1N1 was first starting. We all had to get immunized for it. It was a big thing, so they were calling me to see if I'd gotten immunized and thank me for my documentation because they were able to use that to piece everything together to see what was going on with that patient. Within an hour of me leaving, he was intubated and was doing fine, within a week, but yeah.
What happens in that case, like, let's say the doctor, you're really strongly feeling that the doctor needs to do something, like in your case, he didn't.
Yeah, if I had been a nurse for a little longer and had a little bit more backbone, I probably would have pushed it a little further. I used my resources, which was the ICU nurse that just happened to be coming on in the middle of all of this. I would have gone to my administrator. I feel more comfortable with that now, or I would have talked to a different physician. But in that case, we worry less about stepping on the doctor's toes than the patient's care. But we tell all of our new nurses when they're coming out, trust that gut feeling. If you know something is off, and document it, keep following it. But it ends up, you're not going to have a perfect situation every time where the doctor is going to go right along with you. And sometimes you have a gut feeling and the doctor goes along with you, but it's nothing. But document, cover yourself and cover that patient. Push as hard as you can, I guess.
So again, the bottom line is it should be painting a picture of everything that's going on with that patient. And you'll hear us say that 1,000 times. I should be able to look at that patient's chart and read along and see exactly what was going on throughout the day. So, time, 15 to 20% of the nurses' work time is spent on documentation. So you can look forward to that. You're going to be documenting a lot. Different units document different ways. Some you're going to have to document every 4 hours. Other units you're going to be documenting every 2 hours. In the emergency room, I'm making notes every 30 minutes. I'm recording vital signs and making a note of what's going on with that patient in that room every 30 minutes. There's going to be scenarios and situations with a critically ill patient. Like if I'm doing a flight, I'm making notes every 15 minutes. I'm doing vital signs and making notes. There's going to be situations with a trauma patient where it's going to be every 5 minutes. I'm going to be documenting something on that patient. So you're going to be spending a significant amount of time doing this. That's why it becomes really easy to get lazy. Because you want to hurry up. You want to get done. You just want to get these notes in real quick. So you need to be aware of that. Even though we're spending all this time documenting, we still fail to demonstrate continuity of care and evaluation. So somehow we just tend to be bad at this. There's different types of charting. You're going to hear all different types of names for different types of systems. There is no one system for every hospital. Everybody's got different computer program systems as well as different types of charting. There's text notes where it's one big block. And how long ago did you guys do a lab where you had to go in and do your head-to-toe assessment and then make a note, head-to-toe assessment note? How long ago was that for you guys? Just last semester? Okay, good.
No.
A year ago.
Okay, I was gonna say, it seems, by the time y'all get to me, it seems like a foreign concept usually. It's been so long that you forget what you need to document on each body system. So look at that again. That's not something that you do once and it goes away. You guys need to look back at that and read up on it again. So sometimes it's a text note where it's just one big empty block and you're just writing paragraphs. They can be difficult for you in the beginning. Flow sheets is what we use on ICU and ACU and OB, where you have different body systems it'll say cardiovascular, and then you have little options to click in there, which are great for reminders, but, you know, you don't wanna get caught into a loop where you're just using your clicks. Because my assessment of you should not look exactly like my assessment of her. You are two very different people, you're different human beings, and it's not gonna be exactly the same. So you need to remember that even if you have a system where it's click options, you should be opening that up and making more specific notes to your patient's assessments. There's almost always an option to add, even,
You should be putting what pertains to certain systems in those systems, so if she's coming on the next shift and she wants to teach what were her lung sounds, she shouldn't have to look in 15 different places to find where you documented your lung sounds. So document where lung sounds are, things like that. Different systems, but they're all gonna be really at the core, somewhat, you know, the same, yes, it's hard to, I know when you guys are students, we're all these different places and you have to learn different systems everywhere you go. But really, you're still doing the same thing for your patient, you're still documenting the same things. That, like she said, it gives you a reminder, it helps you to not forget anything. When you're starting out, and then, you know, once you've been into it a month and you're taking on 4 patients or whatever, it's hard to remember everything for every patient, so that gives you a good reminders and keeps you on track with everything. Text notes usually should come in when there's something different,
Any
chest
events.
pain episode, something that's going on, patient fell, something along those things that you need, you know, to really just contain the story in one paragraph, we'll use that kind of stuff.
Using the text notes as an option to do your head-to-toe assessment tends to result in, especially when you're really new, missing data. You'll forget a system altogether because you kind of get overwhelmed in it. And then using unapproved abbreviations. It's really bad in text notes. I've noticed, I mean, it's all the time. I don't even know what they are sometimes. I saw one the other day and I meant to remember what it was and I can't remember and it's driving me nuts. But I was like, what is that? I've never, the whole shit different.
And abbreviations are different from discipline to discipline. I have an office with dietitians. Dietitians will read nursing notes and they'll go, Jen, what does that mean? And I'm like, what do you mean? It's very clear and I understand it perfectly, but they might not. So your continuation of care, you should have it in somewhat understandable terms. I don't understand her shorthand. So, and one of the things I recommend is have your buddy, have your coworker read your note. Chief Lara, I wrote this note, I feel like I'm forgetting something, or does this make sense? I had
Especially
someone,
after an event.
yeah, a couple days ago asked me, can you read this? This doesn't make any sense to me, or I feel like I'm missing something. Yeah, it sounds perfect. You know, if I had nothing to do with it, I'm a perfect example to read it and say, yeah, I can tell exactly what was going on for a patient.
I had a patient the other day who had, she's on comfort measures and trying to document pain because the family had to be educated on how they know that she's having pain because she's nonverbal, she can't tell you. And so I was trying to describe these lung sounds, and all I could sound is it sounds like a moaning sound. So I'm typing it out and I'm looking at my chart. I looked at my chart and I'm like, does this make sense? Like if you got caught, if you had to come back and say, did you give the right amount of pain medication? Is this patient comfortable? Because I mean, this is a dying patient. The family's going to be grieving. You never know what's going to happen in this situation. So like if I were to start 5 years from now, would this lung sound make sense to you? And that's just an example of having someone else read your note to make sure that it makes sense.
Write chart before you start. Nothing worse
Yeah.
than finishing your assessment and realizing you have the wrong chart.
I actually read a nurse's charting yesterday on an intubated comatose patient that said, patient asked to get up and go to the bathroom. I'm pretty sure he didn't, so you know that you're charting in the wrong chart, so
Which is so
Very
easy to
important.
do now because we are clicking with computers, you know? It's so easy to just click on the wrong name. So just look at it one more time before you start actually writing stuff in there. Again, it should reflect the nursing process, response to interventions. Again, if you have given a medication for chest pain, there should be a chronological follow-up that you have reassessed it.
even next
Lasix.
anything you're giving that's an
You give
intervention.
Lasix, better believe you should have some output reported an hour later because otherwise it didn't work, right? Yeah, so then what? If you ignore that, you didn't document anything, but you documented that you gave IV Lasix for something, it kind of looks bad on you that you didn't follow up on it, right?
If the physicians are following 10 or 12 patients, they're not gonna have time to follow around all these different nurses and ask, well, what'd you get for your output after you get that Lasix? They're gonna be looking at the computer, they can look at it from the ER, they can look at it from wherever. They can be looking at the computer to see, man, we gave, 40 Lasix and then they put out 50. So they might order for some more. They can order from anywhere in the hospital. They can order from at home or their offices in most of these places. So they might be pushing these orders without, getting full information. They trust me enough that, well, it's Lara. She had gotten the documentation in there. Well,
And they're gonna assume that you would call, that you are reassessing it, and that you will call them if it's not right. They may not look at that again till the next morning. So just make sure you're constantly documenting follow-ups on everything that you do. Again, painting a complete clinical picture. One of my biggest pet peeves is the person who documents an assessment in the morning, documents an assessment at 11, documents an assessment at 3. And there's no notes in between. There's no activity notes. There may be some vital signs or some outputs or whatever, but my perception of that is that patient laid on their bed with their arms like this all day long and never moved. Because that's what you've documented. You should have notes. The patient's up to the bathroom, the patient's up walking in the hall, patient's up walking 50 feet in the hall with a steady gait and a walker, It should paint a very clear picture because insurance companies are looking at this. Does this person need skilled rehab? Do you know what skilled rehab is? Okay. Patient needs skilled rehab. You know they need skilled rehab. I know they need skilled rehab. The insurance company is going to look at your notes to decide whether or not they're going to pay for skilled rehab. It's not as simple as, we're sending them. No, they're going to look at those notes. This actually is happening right now. There's a patient that, she's a very obese woman, and she wants to go to skilled rehab. Insurance company was refusing to pay for it. So we're trying to get information to them, and they're looking at the nurse's notes, and it has to reflect a need for her to go. Because the insurance company is, oh, she's too young, she didn't need that. Well, she really does. She has a lot of other issues that are factors here, So your documentation is going to be what's going to decide whether or not this is going to happen, and the patient's going to get the care that they need, ultimately, to get them back to their baseline functioning status.
Just to back that up, Lara, she's very correct in that statement, because on the nursing home side, when the nursing home gets a referral for the
First thing you ask for.
First thing you ask for is, where's the nurse's notes? Social worker wants to see that. The administrator of that hospital wants to see that. And the med list, the big ones. Because what happens is that administrator, who usually can be a nurse, is gonna look at all those meds and say, okay, what meds is this institution gonna have to pay for if the insurance won't cover them? And big ones are inhalers, Spiriva,
Yeah, they're
Lara.
expensive.
Oh, big time. And if they have too many of those and their insurance won't cover them, they're not getting in unless they say this patient is gonna rehab quickly and get out of here quickly, and we can recoup our costs. And they look at the nurse's notes. Can our nursing staff handle this patient?
big time. They'll look at patients that may have been a one-on-one.
Yeah.
Nursing homes can't cover that. They
Assisted
can't have,
level of
yeah, they
moving
can't
around.
have that
Mhm.
close of, so we've had it in the past where a patient was documented as a one-on-one, but they hadn't been for like 24 hours. So a patient staying in the hospital and paying, a lot more to stay there for an extra day or two because they want to see them not one-on-one for at least 24 hours or more. So over documentation again can come back. So none of this is overwhelming or stressful at all. Right?
Documentation of preventative measures. Please, 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 please. You have to document what you're doing. Bed alarm is on, little tabs unit is on, the camera is on, and the patient still fell. Well, you did everything you could possibly do to prevent that fall. What else could I have done? Nothing. Okay, well, if I didn't document anything, but that maybe I had said that the patient was confused and trying to crawl out of bed, but I didn't document that I had my camera on, my bed alarm on, and my tabs on, whose fault? Am I negligent? Yeah, yeah, it's my fault that she fell and broke her hip and died. So you have to document that you're using these things. Air mattresses, turning your patient to prevent bed sores, all of those things. If you're not, you may very well be in there turning them and putting a pillow between their knees. But if you didn't document it, it did not happen. You can talk all day long, it did not happen. Because that's your standard. That's your standard of care, that you document that you did that, right? That's all you have, because it's been 5 years. How are you gonna back it up? You've got nothing if you don't chart that you did it. We talked about that a lot. Frequency, frequent documentation. You should have lots and lots of notes. I like to say I should have something documented every hour. If I'm working on the med-surg floor, I'm doing my assessments every 4 hours, I should have some kind of note in there every hour, because the reality is you should be rounding on your patient every hour. And if you walk through the door and you check on your patient, you should be charting that, documenting that you were in there and checking on their needs. Interactions with ancillary staff and family members. If the daughter's at the bedside and I update her on her mother's status, I should make a note that I did that. Because otherwise, she could come back and say that I never updated her on anything, that she had no idea what was going on with her mother.
Do you want to be specific about what you updated her about?
It depends on what's going on.
Yeah,
That's a
you're
real
not gonna document
slippery
every
slope.
little thing that you said, but you can say updated on patient status or things like that.
Updated on plan of care, things like that. Discuss discharge planning. You know, I usually leave it a little open-ended like that unless there's some real specific conversation that needed to transpire.
We mentioned a bunch of these other things already, but one of the other things is like if you send a patient to the OR, when you sent them, who you gave handout communication to.
That's
When the
critical.
patient came back, I was doing a chart review a couple months, well, it's probably a month ago now. And the patient had gone to an OR for surgery. I couldn't find anywhere in that documentation when they had come back, so for all I know, they were in there for 2 days. You need to document when you bring them, when they come back, who you're talking to, who you got a report from. There's always handout communication anytime you bring a patient anywhere. You're sending them out of the facility. You're not going to send a patient anywhere other than home without talking to someone else. If they're going to another facility for a procedure and coming back, you're still going to have to give a report to someone. You have to document that that happened. Otherwise, you're just shipping people out and not giving
disappear.
them that continuity of care.
Jen mentioned the real or exact time earlier, and this was one of the things when I went to the workshop with the nurse attorney that she mentioned very, very specifically. It is one of the biggest red flags in mediation and legal chart review that they look at. There's no way that you're doing everything on the files. 12, 12, 5, 12, 10, 12, 15, which is what nurses tend to do. We just, when we're going back to make notes in our charts and kind of fix stuff, add stuff in, we do it on the files. I don't know why, but we do. And she said that that is one of the very first things that they look at, because they can say, so you falsify your documentation regularly? Well, no, of course not. So how, you were in the room, 1200, 1205, 1210, 1215? Well, no, you know, it was approximate. So you do falsify your documentation.
Especially if you're
It's
documenting
that
like
kind of
two different
loophole
people.
language that they would use with you in those mediations and when they're doing the depositions. That's the kind of stuff that they're gonna say to you. And they're right. There are kind of, you know, it wasn't 1205, it was 1213, you know? But there's no way for you to back that up if you're not doing it, and there's no reason not to do it. Jot the time down, look at the clock, there's a clock in every room, in every hospital across America. And most of the times, if you just do your documentation, you know, I walk in the room, I log on the computer and I click. It captures my time right then. I never have to think about it again. And almost every hospital facility that you're gonna work in has that capability. So even if it's just, you know, clicking a room around or something, putting something in so that that captures that time. And then you can go in and add notes to that later. But you're capturing your time. And if you can't do it, there's always a napkin. There's a sink with a napkin, and you write on it, and you put it in your pocket. So if you don't get anything else out of this, please be very, very cognizant of that, because it's one of the first things they look at. Sorry, my soapbox.
Those are the soapbox. No. We've kind of touched on some of these things, inconsistent or incomplete charting, not painting that perfect picture that's gonna see what's going on. Gaps in your documentation, kind of like, well, they went to the OR when they come back. And then all of a sudden, they're eating supper, so what happens in between? Symptoms without what you did about it, so not putting those interventions in on we talked about. And using unapproved abbreviations, this is a big one. Once upon a time, we abbreviated everything. Really trying to cut down on that quite a bit, and like I said, it disrupts that continuity of the care if one person can't read the other person's abbreviation. And people come up with their own. Well, I understand my charting, well, that's great, but no one else in the facility does. So you need to, PT and PT, patient physical therapy. One person can write it for one thing or another. Do you have a?
Do you have it like a carry approved list that you can use these
Yeah. Every facility has one, and we'll get into that in just a minute.
And they're going back to one of the first things we said about Joint Commission, they regulate a lot of those. We pull our do not use lists pretty much from them, so, and I'm sure most facilities do. The nurse mediators and nurse attorneys that we've spoken to gave us a list of words to avoid. These are like red flag words for mediation and depositions apparently. Unintentionally. That really kind of, that's an interesting word. I unintentionally gave that Lasix. You know, you don't want to say that. It looks very, very bad for me. You know, I'm kind of omitting or admitting some guilt there. Inadvertently, unexpectedly found the patient on the floor. Okay. Appeared to be, I see this all the time. They appeared to be in pain. Well, what does that mean? Did they have, like, what was the appearance? What made you think that they appeared to be in pain? You should be, as a nurse, describing signs and symptoms, not what appears to be. Apparently seems to be, feels better. That doesn't mean anything. What are their vital signs? What is your assessment? That's what you should be documenting, not feels better.
I do tend to write feels better, but then I follow up with freeze, pain, 0 on 10. And there's a FRAC score, which is the.
You can put in quote, patient states I feel better.
Yeah, that's
You
a
could
big
certainly
one.
use
Yeah.
quotes.
That
Quotes
states
are great.
a lot, yeah.
Yeah.
Patient states no pain, but then, you know, describe things a little bit better, what's actually going on. Patient on smartphone, walking around the room eating a bag of Doritos. It's gonna describe what's going on better than what they said, it's a 10 out of 10. No, maybe not. They're, you know, bouncing around the room and going to visit all the other patients, they might not be in that much pain.
Tolerated well. This is the slippery slope. This is the thing that, like, I was taught in nursing school after every procedure, you document the patient tolerated it well. Apparently, this is not a good thing to do. Apparently, it's better to, you chart the procedure, the assessment of the patient at the beginning of the procedure, and the patient at the end of the procedure. Tolerated well is, again, one of these vague things. What does that mean? It can be one of those little loopholes that they tie you up with in those depositions and mediations. So they're saying not to do that. Just document facts, document your assessment and your vital signs.
Everybody's perception of thing is different, you know, it may look to you like they tolerate it well, but they may think, oh my God, this is the worst day of my absolute life, and I'm just painting a smile on my face because I like the nurse and I don't want her to feel bad. They change the way that they act a lot of times because, oh honey, you're busy, I'm fine. And then you leave the room and like, oh God, that was awful, I feel, you know. So get facts from them, say, you know, just tell me in your own words and use those quotes when you're documenting.
The other day I was documenting a patient who says, I don't want to tell you how I feel because
Oh,
I want to
I
go
remember
home.
that.
And I'm like, okay. So I'm doing my notes and I'm like, the patient wasn't honest with me. Claire's like, you weren't honest, shouldn't quite, doesn't sound right. Straightforward would be a better word. He really wasn't. He was discharged, but he said, no, I'm okay. I'm okay. I'm like, well, it was okay. Did you document what he said or just that? I documented what he
Oh,
said
yeah.
and I also followed up with
what could happen if he isn't straightforward, and some of the other things that could happen if he goes home and has these same symptoms, but he's not being truthful with himself, and what could happen if he wants to come back.
We kind of skipped over it on one of the last slides. One of the things was not being being vague, like patient voided a large amount. That doesn't really mean anything, small amount. Try to describe it. You see all the time, like a dime size spot of blood. That paints a pretty easy picture for everybody. Everybody knows what a dime size is, right? So large amount, measure it. It's 200 mLs. And then describe the color and everything else.
Right, if they're
What's that?
incontinent.
Right,
Yeah.
You can say something about
Incontinent.
that they were incontinent and that, describe it as best as you can. Right,
Yeah.
something that gives you a good picture, again. More-
Abbreviations. Avoid them like the plague, that's what I say. Know your facility's approved abbreviation list and only use your facility's approved abbreviation list. Make sure that if there's capitalization of letters, that you use that. If there's, any periods in between things, that you use those. And just remember that they can be so easily confused. PT and patient is one of those ones. And it sends a very unclear message, and it doesn't make it easy if somebody needs to read your charting. Like if I was coming on shift after Jenn and I needed to read her charting for whatever reason, if she's got all these crazy abbreviations in there but I don't know what they are, then I'm not getting a clear message of what's going on with that patient, and neither is the physician.
Let me go over some specific actual documentation examples at the end when we're done our spiel.
And
You'll
again,
see some of them.
Are you gonna know what you meant 5 years later?
And this is that do not lose list that you were asking about. This is straight from the Joint Commission. And I think I know some of you won't stay local, but all of the county hospitals do follow Joint Commission.
Everybody
rules and
wants to be
regulations.
Joint Commission accredited because that's optimal reimbursement from the insurance companies. So, if you're working in a hospital facility, you're probably going to have Joint Commission involved in your career.
So these are some examples, and they might have already gone over this in school for you, but instead of typing out or writing out unit, can be mistaken for 0, a port, or CC. A lot of this is for handwritten things, when you're writing a physician's order, a telephone order, things like that. That has been cut down on a lot. Most of the things, especially with our facility, our physicians can make orders from wherever they are. It does happen occasionally, and there's going to be some, it doesn't matter what type of, even if you're doing home nursing, you're still going to be writing some orders occasionally. Nursing homes are still going to be writing orders occasionally. But you need to make sure when you're writing as clearly as possible and you're writing things out. IU, not used very often, but international unit can be mistaken for IV or 10. QD or QD should not be used for daily. They can be confused with some of the other ones. QOD for every other day. Write out daily, write out every other day. Trailing 0, I believe that they teach you this in school, right? I know we were taught with that, but don't ever put a trailing 0, and don't ever have a lack of a leading 0. So that little decimal can surely be mucked out pretty easily, and you'll see in some cases where people have given the wrong dose. They've given 10 times the dose that they were supposed to, and patients are going to be really injured by a lot of those things, especially if it's tough medications like epinephrine or heparin or things like that. You don't want to be the ones to misinterpret it. What do you do if you're reading one of these and you don't understand what it says, or you think, geez, it could be this or that? Call. It's going to fall back on you. Always
What else
call.
do you do
Inquire.
if you call? You write a clarifying order, yeah. You document that and you literally rewrite clarified order and rewrite that order.
Usually there's a lot of people that it goes through, but even though it's going through 3 or 4 people's hands, it can be misconstrued by every single person in that path. And then morphine, magnesium can be misinterpreted for each other.
On your discharge instructions, you always want to make sure that you're filling out all the appropriate forms, that all the appropriate documentation's been done. that you have an order to discharge. I've seen that happen before. The doctor had said that she was going to discharge paper. I typed up some discharge instructions, but never actually wrote the order. So the nurse discharged the patient, and then she was like, well, where did he go? And the nurse is like, what? I did not discharge him. So,
It's a good interpretation.
yeah. Always document who's in the room. Because if somebody's a little confused and you've gone over the instructions with his wife, who's very with it and manages his care, great job, but you better document that you did that with her, because you could get in some trouble on that later on. If they're send someone home with Lovenox or new insulin or something, always want to document the teaching that has led up to that discharge, that the patient's understanding, that there's been demonstrations, return demonstrations. Otherwise, the patient can come in and, well, nobody showed, and that's happened, nobody ever showed me that. You know, nobody ever explained that to me. Dates and times, medications, diet, activities, understanding, and that the teaching's been done. Always make sure that you document appointments that are made, because you can get in a lot of trouble with Joint Commission and CMS for discharging patients with no follow-up. That's a
Every
big
patient,
news.
once they're going to a nursing home, every patient, they're going home, every single one, and every single one, and every single one will have a discharge appointment. They're gonna have some type of follow-up with their primary care. Doesn't matter what they were there for, even if they've had COPD flare-ups 4 times that month, doesn't matter, they still need to make the follow-up appointment.
Every discharge that I type up, I always end it with patient verbalized, discharge instructions sent home with patient verbalized understanding of all instructions. I closed every single discharge paragraph with that. I gave them a copy, that had their teaching and everything, and that they understand. Also belongings, I want to document getting their stuff back.
I think we kind of talked about that, like she just mentioned, any education.
And Joint Commission regulates education. Every single patient must have education. It must be documented. If there are medications, new medications, you have to document that you gave them education on new medications that you sent them home on, as well as procedures.
We mentioned pain, that it's a really big thing, and that's one of the things that'll come back, right? It's one of the things that anyone that comes into a hospital, I don't know how it works in a nursing home exactly, because I've kind of stayed away from nursing homes. Do they do any type of, like, follow-up evaluation? Like, we use avatar surveys. There's some type of surveys that go to patients' home. They really drill in on your pain, and then was it really well controlled or anything like that. They really gonna follow back on that. Whatever your scale might be, the Wong Bakers, the faces, most places have those signs where you've got the smiley faces or the really unhappy faces or the crying faces. Frag scale is for patients that can't speak verbally. So you're checking them out, like Heidi was mentioning about a patient earlier that couldn't speak for themselves, so she's teaching the family on what to look at of that patient that you need to be paying attention to. Are they grimacing? If you go to move them, are they clenching? You still might be doing those things, even in a patient that might be dying. If their heart rate's going up, things like that, you're gonna be looking at some of those and try to evaluate it, and you're gonna come up with a score by using that FRAC scale. And then just the regular numeric scale, and it's 0 to 10, not 1 to 10. That comes up.
Yes. That, and you cannot say, if the Joint Commission says that if your facility uses a scale, you use the scale. So if you have the 0 to 10 pain scale, which most facilities, that's what's used, you can't say patient denies pain or patient has no complaint of pain. You have to use the numeric scale. You could say patient denies pain 0 over 10, but you have to use the numeric scale, and you have to be consistent, because that's evidence-based practice. That's what we're evaluating. We're using a consistent method across time to evaluate this patient's pain.
Anxiety scale, I'm not sure other facilities fall on that, but we've incorporated the anxiety scale, and if you that have been to our facility can see that. We work that into our pain, because sometimes people are having more anxiety and are interpreting it as pain, or vice versa, or they're having a lot of pain, so it's giving them more anxiety. So incorporating that into your evaluation of their pain, and always fall back on the reassessment.
And remember that it's not just, you know, removing the wrong leg that the facility can be sued for. Failure to treat pain has a lot of legal implications, and it's becoming more and more common where patients are making complaints, patients are making lawsuits because their pain's not being treated. So you have to be 100% with your pain assessments and do it consistently and follow up on it. If a patient's reporting a pain of 10/10 and 10/10 and 10/10, and you're documenting 10/10 all day long, but you're giving them the same medication and not making any changes or doing any follow-up or referrals with the physician, is it negligence?
Yes.
Caused injury?
Yes.
Harm? Yeah. So it comes back on you. And again, if it's a 10/10 and we're talking on our cell phone, texting and needing Doritos, that paints a different picture. But you should still be notifying your physician, because no matter what, you have a duty to notify the physician and maybe look at the orders. And it is, you know, you have to remember that it is, every patient's perception of a 10 is different. My 10 is not Heidi's 10. My 10 is not your 10. You know, they may say 10, but somebody else might have said 5. So I always kind of give a patient a little bit of education on what that pain scale means. I always say 0 is no pain at all, 10's hit by a truck left on the road. That's what I give people on that scale. And you also set a pain goal. There's going to be patients who have chronic pain. They're never going to be 0. A post-op patient may not have chronic pain, but they're never going to be 0. You're not going to get a 0 with a hip replacement. Not going to happen. So you set a pain goal and you document that goal. That way, when you hit a 3 and that's the goal, you're golden. You know, you don't need to be going to the doctor to get new orders because you've met your pain goal. So remember to do that as well. Remember everything. Which
Did you
patient?
work that out between you and the patient? It's usually either before surgery with 1 day, or you're the nurse before they go over it, when you're admitting them. You set all those goals, your anxiety goal, your pain goal, right off the bat, and then everybody works off of that. And that might change, that goal might change, and then that's something that you work out with them too. Grammar.
No.
Yeah.
All right, so there's not a whole lot of writing anymore as far as handwriting. Most places have gone computerized and, you know, computer order entry and all that stuff. So the legibility is not as bad an issue, but, you know, it still happens. Yeah, it has to be legible. It has to be. If you can't read it, don't guess. You call, you clarify, you rewrite the order. When you're writing something, please just pause. And I have the worst handwriting in the history of the world, and I can own that and admit that. But when I'm writing an order, I take my time, and if it looks sketchy, then I redo it. Correct spelling. There's some pretty fun little
Yeah.
errors. Always read your notes before you save them, because you'll find that you've got some pretty, especially with the computer keyboards that have those little infection control, like plastic barriers over them. The keyboards are all, it's weird to type on them, and you'll have some pretty bad errors. Poor grammar. You are professionals. You should speak like a professional. Your charting should reflect that professional speech. So please, read before you save.
What did we find once?
Boo-boo.
Patient had boo-boo.
I'm like, really? Really?
Yeah.
A boo-boo?
Patient had boo-boo.
Oh, what the heck?
Yeah.
Somebody, can anybody tell me what a boo-boo is? Is it open? Is it closed? Is it a bruise? Is it a hole? I don't know. I mean,
Yeah.
I was shocked. I really wanted to find that note and put that in this presentation. I was pretty horrified. Oh, yeah.
So, kind of recapping on some of the things. Being specific, we already said, you didn't chart it, didn't happen. Is it relevant? Are you charting about,
You know what we mean by is it relevant?
you mentioned it just for a little earlier. Right, is it
Yeah.
pertinent to what's going on? Did they come in with a blue t-shirt on? I know
That
I
is-
think dramatic or exaggerating, but you get the point, you know, it doesn't really have anything to do with their care or what's going on.
I like seeing the triage box in the ER. They come in with a toothache, but they give you this whole description of what led up to the toothache.
Yeah.
And really,
I'm not going to type every single thing that led up to that toothache. I'm going to describe the toothache.
Keep it short and sweet, so you said don't put yourself in a legal situation where you're over documenting something that happened.
If you make these big, elaborate paragraphs that go on and on, you kind of get lost in it. You know, it should be very, I always tell people, black and white. You know, the patient complained of chest pain, mid-sternal, sharp, constant, with shortness of breath. It's very, very black and white, very, very fact-based. I'm not getting into these big, long, dramatic sentences because it's very difficult to interpret that stuff later on. If it's black and white and it's fact-based, assessment-based, you cannot go wrong with that. You've got everything in there that you need to describe your assessment and what you're doing about it.
You can say patient lying motionless in bed. Well, are they dead or are they just watching TV? You gotta give a little bit more, be more specific, and is it relevant? Well, if they're lying motionless in bed watching TV, you don't really need to write that they're motionless in bed. Patient watching TV, and then elaborate on whatever else is going on. Lara mentioned it a little bit earlier, like if you don't wanna set yourself up for a bad situation, and there's other ways of dealing with these things, like if there's a piece of equipment that wasn't available, you're not gonna document, you know, vital signs card was not available because Susie took it and I needed it more, or whatever. You're not gonna write that the equipment wasn't available. You're not gonna write, I gave the wrong medication to this patient in error. You're not gonna write those things out and say, I made this big mistake. There's ways that we document those things, and it's kind of by facility, but you're not gonna set yourself up in your documentation, or please don't set yourself up in your documentation doing those things.
Refusal of treatment as well. If the patient's, I don't use refuse, I always say decline, it sounds nicer. Or decline to do this. You wanna make sure that you're documenting that you've offered, if it's a medication. I oftentimes run into the patients not wanting to get up and walk thing. I document every time that I encourage a patient to walk or offer to take them for a walk. I document it because there's so many complications that happen from not walking. We know this, it's a fact. So, you know, you've gotta document your efforts as well. Even if they don't wanna go, fine, don't go, but document that you offered it and that they declined to go. Because now the onus is shifted back on them, not you. When documenting patient statements, try to be specific and use their exact words with the quotes like we talked about. Do that, if you know, especially if it's in some kind of situation or event, if somebody's threatening to leave AMA because they hate the doctor, you know, you want to document what the patient is saying as to why they're leaving, why they're refusing to do something, why they're refusing a treatment. You want to document what they're telling you and be specific with that. Letting patients leave against medical advice is a slippery.
Lara mentioned pretty well already about physician notification documenting, call that you made. Document if you tried paging Dr. So-and-so 4 times and you haven't gotten a call back. It's not your fault that the patient, that the doctor can call you back if you've paged them 4 times. You've called their home, you've called their life, you've called their dentist's office to try to find them. Document what you did to try to find them. And if, you know, a little bit of time has gone by and you haven't heard from them, document who you've turned to, and that you know, Dr. Romo wasn't available, so or not saying it that way, Dr. Giovanni notified, you know, in the end. You don't have to say, well, I paged Dr. Romo 4 times and he failed to ever call me back. Just say, page Dr. Romo at this time, page Dr. Romo at this time, and every time just short and sweet with those, exactly what you did, and then turn to someone else. Dr. Giovanni notified, these are the orders I got.
Receiving orders by the physicians, telephone orders, you're going to have to make sure that you are following your facility's policy and procedure on that, as well as
Joint Commission is
Joint
pretty
Commission.
hard on that as well.
Because basically, if a doctor tells you to do something and you don't write the order for it, you're kind of practicing medicine without a license. So you have to follow that up with those orders and writing them down in the chart. Always write it while you're on the phone with the doctor, read it back to them, and get a confirmation that it's correct. You understand that process? Always, because you want to make sure that what you're hearing and what they're telling you is what you're writing, because it can be easy to make little errors during those conversations.
Or sometimes even just in the reading back, they'll might say, oh no, that's not what I meant, you know, they might be in the middle of doing something and they just kind of spouted something off and you're kind of working together. That's what the R&V means, read back and verify.
One thing that people tend to not know, I don't know where this lack of information comes from, but you know what I mean by code orders, DNR, DNI, full code. Do we know what that means? Okay, you can't take a verbal order for that. The doctor can't tell you, oh, make up DNR, DNI. No. They need to get the chart. There's a handwritten order that they have to do to make that a legal thing. You cannot get a verbal order on that ever. It's a legal requirement that it's be done properly and written.
Even if that patient's been DNI for 10 years, sometimes in the moment they change their mind and no, I'm scared I didn't mean it in a full code, and you educate them further. If they really still mean with their full code, then they can change their mind. So even if you look back in their chart, and they have old charts this stack this high, they've always been in DNR, DNI, you can't necessarily carry that over from time to time. It's a new order every time.
Well, an advance directive is a form that's kept in the permanent medical record, but every time a patient comes in, the doctor has to write what their code status is.
So that may carry them, but.
And they change their mind all the
Yeah,
time.
it can very well be ripped up and thrown out from nursing commission, so.
Changes in conditions, so these are those events we talked about, when a patient starts kind of going downhill, things start going poorly. You want to make sure that you're documenting, again, very specific assessments. Avoid ambiguous language. Vital signs, vital signs, vital signs. They should be carried on throughout the event. Fact-based, accurate, black and white language during these events. Who's in the room? What are we doing? You know, if you've got a physician and 2 other nurses in the room, you should have it in your note. Who's in there? What are they doing? What are you hearing? What are you seeing? What is your assessment of the patient? Does it tell the whole story? Can I read this and tell what happened in that room from A to Z? And I always just have somebody else, like Heidi said, have somebody else read your note. Because otherwise it gets a little gray. So you might forget something, or you might have gone on a little bit too much about something. Just have somebody else read it. You can never go wrong with that.
The when is very important too. If the respiratory therapist is there, that's important. Some of these things come back, especially if it comes back legally, or it just comes back in some type of review within your facility. Usually most facilities have some type of review committee where, boy, this was a situation that didn't really go how we wanted, let's pull everyone in that was involved. You gotta document who was there, if the respiratory therapist was there, if whatever else might be. The physician, right in when they get there, because once you get more training, there's a lot of procedures you can do in emergency situations without a physician. Once you're ACLS certified, I could run a code by myself if I wanted to without a physician there. I can call out what meds needs to be given and everything. If the physician shows up and takes over, someone needs to know what time that happened, so that the responsibility is more so on them. Does that make sense?
And reassessment and how the patient's responding to those interventions. I was chasing my tail for 2 hours yesterday with a patient with a blood pressure, and I was constantly making little notes. I stayed at her bedside, the doctor had told me to decrease the fluids and her blood pressure went back down to 73. I turned it back up, you know, and then I told the doctor that I turned it back up because I know that I need to do that. The patient's getting into shock, but I also have joint commission order or joint practice orders that I can fall back on that tell me I can do that. But then I also make a note right after that that I've notified the physician and the orders were changed. So you constantly reevaluating what's going on with the patient, what's working for the patient, and your documentation should back that up.
Does anyone know what joint practice orders are? Something like, it's probably facility to facility, and I would imagine it's just in hospitals. If Lara's my patient and I can't get a hold of a physician and she has very specific situations that are going on, each facility will have a set of joint practice orders that you can fall back on. You're not gonna let a patient, if she's going into cardiac arrest, I'm not gonna be like, oh man, I gotta wait until so-and-so is here, and he just went to McDonald's, and I'm gonna wait for him to come back, and I can't do anything with her. You're gonna do some things with her. You're gonna get an EKG, you're gonna, you know, start her on oxygen. You can do those things without an order per those joint practice. Once a physician is available, he's gonna have to review those orders and sign off on it. So that's the joint part between the nurse and the physician. They're gonna have to do the follow-up on it as soon as they possibly can. Our facility has things like, if they have a headache and there's nothing else going on, we can, if we can't get a hold of a physician, we can give them 650 milligrams of Tylenol one time. We can't do that for fevers, so it's very, very specific within your facility, within those orders, what you can or cannot do. So like she said, if their blood pressure is bottoming out, they're symptomatic, you can, you know, bump up their fluid or give them fluids, but it kind of goes more with once you have a little bit more experience, talk to your coworker, geez, is there anything I can do? I can't get a hold of Dr. So-and-so, and you can kind of put some of those things into play. Very short list, very specific.
Would those be the same as like standing orders in other places?
Yeah,
Okay.
yeah. Except for they're not included in every patient admission. It's in our nursing policy and procedure.
Oh, okay.
Yeah.
We've got respiratory distress ones, we can get an ABG and put on oxygen. Hypovolemic shock, give fluids.
Some of the standing orders are like if someone's admitted with chest pain, we'll have standing orders where they
Right.
can do nitro, you know, Linda. If a patient's not admitted with chest pain, they're not gonna have those standing orders, but
Right, right. Okay.
anyway, just one thing to learn once you're in your.
So one is more,
facility.
like a standing order would be more diagnosis
Yeah.
specific,
Yeah.
where it carries joint practice orders.
Right.
Kind of are an agreement between.
Yeah, it's one of our.
I think there's like
actual-
5 things on there. There's not many, but they come in handy.
And they
Like-
can be universal.
Yeah,
for-
like example,
Okay.
if you have to put an NG tube in someone, getting the KUV x-ray afterwards is
Mhm.
part of our joint, and we've fallen back on this with physicians before that say, I don't want you to get the KUV, because if you listen, you should be able to hear that
Mhm.
it's in place. Well, sorry, it's part of our joint
Yes.
practice orders
And-
that we can and we will.
It's the
Yeah.
gold standard.
Right.
Yeah.
Yeah.
Exactly.
Yeah.
So always use the SBAR format. Anybody know what that means? Response. Yeah, yeah,
And
response
it's-
or recommendation.
I just say, as someone already looking at the fact sheet of your handouts, so whether you know it or not, you're probably following those things along when you're doing, your handout communication, or your documentation, your communication with anybody else that has anything to do with that patient.
And these are really good to use in those emergency situations, or what they call rapid response, where a patient's not coding, but things are going very poorly, they're going downhill, and you need quick intervention. This is an easy format to follow, to convey to the other people in the room who are there to help you, what's going on with the patient, and then what your assessment is, and what kind of recommendations, what are we gonna do about it? And, you know, the doctors don't always like chime right in. Sometimes, well, hey doc, you want me to get this? You think we need one of these? They trust their nurses, they develop relationships with you, and they'll often, oh yeah, get that. Document response, patient lead times, we talked about that. Starting as you go. If you can open a computer in the room during an event and document as you go. It's a lot easier than trying to go in and fill in the blanks later, but again, the napkin will save you.
Yeah, we've mentioned most of these things already.
Medication events, if you give a wrong medication, what do you document?
And one other
Oops.
example,
So where we do it at our facility, there's a little button called the shift summary. It's kind of this little blank box that comes up
it
after you
just
put
says
that.
medication event. when
Yeah.
you're doing
And then you just document, for instance, if I gave Lasix to the wrong patient, I would just go in there and I would document Lasix 40 milligrams PO administered, MD notified, no new orders, and then see vital signs, and I'm gonna have some vital signs in there, a little extra vital signs throughout the day. You're not gonna write medication error or gave med to wrong patient, don't write that. That's kind of like a beacon
Yeah.
to the eye of somebody reviewing charts.
So
But
it
you
goes
have to
further.
document that you gave it.
Yeah, like if you're pulling a vial of something, let's say you're pulling Lasix IV, and it comes with twice the amount of what you needed to give, but you forgot to get rid of the other half of it, you document Lasix 40 milligrams IV ordered, Lasix 80 milligrams IV administered to patient, Dr. Roman notified, will continue to monitor, no new orders at this time, or whatever it may be. We'll be bringing patients to the bathroom a lot, don't document that.
Doesn't that go in your variance though? I mean,
There's
is
a
that
separate
separate
form.
stuff?
There's a form that goes to pharmacy.
And those never go in the patient's chart?
Never.
The variance does not go in the patient's chart, but you do that little documentation, and we actually print off that note that we wrote in the shift summary and attach it to. That's just our facility, how they do it, but there'll be some variation of that in every facility that you go. You won't be just having a medication incident and then just be like, oh man, that sucked, and carry on. You're gonna have to have something that follows it, but like she said, you don't wanna write, gave patient the wrong medication, or gave med to the wrong patient.
So also following up the patient's condition after, like if somebody falls, you know, you're gonna document, you know, the patient found on floor, assisted patient up, time 1, you know, patient has no complaints of pain, 0/10, no deformities, no injuries noted, no bruising, things like that. A neuro assessment, vital signs, physician was notified, patient's family was notified. You want to document those things as well. And there's always a form that goes along with any kind of variance that you're gonna have to do as well. Do you know what that means? The difficult patient?
And not like they just crashed and, you know, they're difficult, time-consuming, difficult patients.
Psychologically difficult patient? Okay, have you had any of those, has anyone encountered one of those yet? A lot of y'all work as CNAs, and have you had one? Yeah, okay. So, language is very, very, you know, specific in this situation. You don't want to document that somebody's difficult, you don't want to document that somebody's crabby, you know. You do have to document inappropriate comments that the patient's made. You know, you've got to include that. Sometimes it's that they need mental health help. We had a patient that resided with us for a long time, and she was very difficult, and she
By
made,
example, she told me when I was pregnant that my baby was making me mean. So that's a little difficult to deal with, especially when you're pregnant.
but you don't want your documentation to look biased as in you don't like her,
Right.
you know, or that the nurses are mean to her or judgmental of her. So again, just very black and white, a lot of quotes of what exactly the patient is saying, use their own words. You know,
Well, she
the
said especially-
emotional support provided to her. It's always a good thing to say.
If you're trying to get placement for them, I don't know if any of you guys are
God,
familiar
yeah.
with how poor site placement can be and how hard it is to get patients or anyone that's looking for some type of site treatment. It's really, really, really difficult to get them in there. That's why hospitals keep patients sometimes for 3, 4, or 5 months at a time. You would think that's kind of bizarre. It happens a lot. some type of help. So it's, boy, if you can have good documentation to see exactly what's going on with that patient and why they need that help, it's gonna help them out that much more. Not because you wanna get them out of your facility and you're tired of dealing with them, but you want them to get the help that they need, right?
You wanna make sure that, if a patient's saying that they're going to sue you or they're going to sue the hospital, that needs to be documented, and then follow up that you notified your supervisor or administrator on call, whoever it is you notified. You wanna document that you've notified them of that. And again, be careful with your language, because it can appear as though you're prejudiced against this patient and that you're treating them poorly if your language is harsh. And document de-escalation. Your job is to de-escalate this patient in that moment and provide them with reassurance. And sometimes, they're just feel like crap and they're angry. We don't see patients at their best. Their life is not a rosy little garden when they come to us. There's usually some stress and an event. And sometimes just sitting down and talking to them and giving them that emotional support will de-escalate the situation. But if not, you need to remember your safety and the safety of others and the safety of the patient, and just start using actual de-escalation techniques with them. And document.
All right. So we have some real life documentation examples.
Do y'all need a break before we do the? Okay, go. 10 minutes? Yeah, we can do this in 30 minutes.